Hello, everyone. My name is Ricardo Romici from São Paulo, Brazil, and I'm happy to welcome you all to our first 2024 global webinar series entitled The Current Knowledge and Future Directions, the Full Cycle of Psoriasis Care in 2024, Value or Volume. Just some brief housekeeping notes. Our webinar today will last 60 minutes. Please leave your audios muted, and you may send your questions through the Q&A button or also through the chat button. Translation will be available, so just turn on the closed captions for all your language options. This webinar is being recorded, and afterwards this recording will be available at psoriasiscouncil.org. So I will briefly introduce the IPC. So our mission and vision, we are certainly passionate community of researchers and physician experts who share a common goal, improving the health and well-being of people with psoriasis worldwide. We understand the challenges of people with psoriasis which they face and are committed to making a difference. Our vision is to create a world free of the burden of psoriasis, where people with psoriasis worldwide have access to the best available care and are empowered to lead healthy, fulfilling lives. Our global network is composed of about 200 professional psoriasis experts, volunteers, representing 48 countries. And all in all, we have 2,000 psoriasis enthusiasts from 95 countries. Stay up to date with our IPC. Please feel free to subscribe at the button on the left with this QR code, or just follow us, like us, and tag us. Here, our next IPC events during the year. Please save the date. We have 5 bigger meetings happening, 2 in September, 2 in October, and 1 in December. Participating at the European Research Dermatology meeting, at the Regional Congress Dermatology meeting in Kuala Lumpur, and in the end of the year, the Gene to Clinic meeting in London. And we'll be very happy to welcome you all. So this cycle of psoriasis care is composed of 4 different series. The first one happening today, Value or Volume. The next webinar called the Integrated Practice Model on September 20th. The third one called Can We Deliver the Best Value Yet on October 31. And the last one, the 4th one, the role of doctors and other healthcare practitioners can play on November 14. And now I'm happy to pass the word to my co-chair today, Dr. Deepak Balak. Please, Deepak.
Ricardo, thank you so much, and a good morning or good afternoon for all of you. It's a great pleasure to be with you today and introduce the topic of this first global webinar, which is focused on value-based healthcare. And today we're going to introduce you to this very interesting topic, and we'll discuss and explore how this novel, innovative way of healthcare delivery can improve the care of patients with skin disease in general and patients with psoriasis in specific. And we're really happy that we have a highly experienced and passionate faculty today to discuss value-based healthcare. And this is the agenda of today. And the first speaker of today will be Willem Jan Bos. Willem Jan Bos is a colleague of mine. He's a nephrologist by training who's working at the Leiden University Medical Center, but he also works at a large teaching hospital in Utrecht called St. Antonius Hospital. And Willem Jan Bos chairs a professorship in improving care in nephrology, and he's one of the pioneers in the Netherlands, but also international, on the introduction and implementation of value-based healthcare. For instance, he's one of the co-founders of the Linnaeus initiative, which endorses value-based healthcare in the Netherlands. And Willem Jan Bos, we're really happy that you're joining us today, and please have the screen.
Thank you very much. And while I'm starting and start sharing my screen, there is one more disclosure. My father was a dermatologist, so I was exposed to psoriasis and dermatology at a young age. But let's start with value-based healthcare. To start the introduction of value-based healthcare, great minds have been able to summarize complicated theories and complicated matter and condense it into a simple formula. You see Isaac Newton, you see Albert Einstein, and I think Porter and Thijsberg together did something similar. They summarized, or they condensed, a very complex field of delivering healthcare into a very simple formula. The formula of value determined by outcomes and costs. I'll give a more extensive introduction. There is lots of variation in clinical medicine, and these are data of a few years ago. And what you see, there's two times variation in survival in severe diseases like colorectal cancer surgery, up to 20 or 30 times variation in cataract surgery, in hip surgery, in large procedures. We do have these differences, and we could say, well, we should be ashamed that there are so many differences, but we could also use it as a challenge and use it as a chance and realize that variation helped us develop the biology we have, and the variation, it drives the evolution as Darwin has described. So we can really use the variations and see where we can improve. And somehow I'm having troubles moving to the next slide. Here we go. And if we want to look at variations in outcome, we also have to think of the type of outcome we want to look at. And normally, especially in larger procedures, we look at survival, we look at mortality. And here's an example from urology to have something neutral. And you can see the differences in 5-year survival between the German national level, the Swedish national level, and one single clinic hardly show any differences. However, if you go to other outcomes, which might be very important for patients, like continence 1 year after surgery, erectile dysfunction 1 year after surgery, you see major differences in outcomes which are not as hard as survival is, but might be very, very important. So we also have to look at outcomes different from the very hard survival and mortality rates. And then there is another problem. A problem we have faced in all our Western countries is that spending on healthcare outpasses the spending or the growth in the gross domestic product. And that is something you can afford as a country for a while, but you have to start thinking how to tackle this problem. And in theory, there are 3 possible solutions. You can keep increasing healthcare spending, which won't be sustainable in the end. You do need money for schooling, for your roads, for your army. And the other approach could be to just put a lock on your front door and start rationing, which is not really ethically, it's not something we should do, and it might be politically difficult. The waiting times will increase, and you might miss early stages of diseases. So if there is a theory which promises to increase efficiency, to improve the outcomes, and at the same time reduces cost, it's attractive, both for practitioners and their patients at the micro level, for hospitals at the meso level, and for governments at the macro level? Can we combine all these outcomes? And that's the promise Michael Porter did in his, and we should realize he's coming from the Harvard Business School, so it's a business theory where he proposed to have competition on results, but also on finances, to improve healthcare, but also to keep the growth of the funding and keep the growth, restrain the growth of the budgets. How did he do so? By proposing the theme of value. And actually, in the first slide, I introduced 3 formulas. In a real mathematical formula, you have same type of outcomes on both sides of the formula, which we don't really have here. Health outcomes are a completely different entity than costs are, but you can discuss how you can obtain value by doing the right things, which is effectiveness, reaching outcomes which are important for patients, and also delivering the healthcare in an efficient way, doing it with the right cost and at least not too much costs at the right place by the right people. And in this way, you can unite the interests both of the practitioners and their patients in the office, the interests of hospitals and the interests of society. That's why many people think this is an attractive theory. What happens? I think in the office, we provide optimal care. There's a lot of focus on shared decision making, which care is appropriate for which patients. On the level of a provider of a hospital, you can design how to deliver the care, and I think Deepak will show some more on that. And on this level of society, we try to keep the healthcare costs low and try to organize healthcare in such a way that we are able to keep it staffed. And to do so, Porter suggested an agenda of 6 points to integrate, to coordinate and organize care in integrated practice units, to measure outcomes, but also to measure cost, to be able to argue whether you do or you don't obtain value for patients, to reconsider your payment model in order to pay for quality rather than paying for volume, to integrate systems between primary care, secondary, tertiary care, and then something more American, to expand the geographical reach. I think it's more difficult in densely populated countries like the Netherlands. And what's always a challenge is to enable and to provide an adequate information technology platform. And actually, your next speaker suggested to expand this agenda and to organize, Paul van der Nat, an elegant paper suggested to organize quality improvement as well, to use this system and to use these data in patient communication, again, integrating care, but also to invest in the culture needed and to provide learning platforms as we did with the Linnean initiative. And of course, if there is a new way of thinking, there's also critique. There's lots of critique on value-based healthcare, and I want to take you along. There is the critique that it's mainly a way of delivering healthcare. There is the critique that it's just patient empowerment. There is the critique that it's a governance discourse to reduce costs, and there is the critique that it really designs the world in a way that everything is manufacturable. And if you take these critiques together, if they're all true, I think we're doing a pretty good job in combining and connecting both the patient empowerment and the professional way of healthcare delivery and keeping healthcare sustainable. And a common denominator, which was not as much mentioned by Porter, was the shared decision-making, which is really an important issue. And then to a final slide, to summarize it all, it's really about effective care which helps the patient obtain those goals which are important for an individual patient, to organize your care efficiently. And if you have less complications, your care is more efficiently. And if I take some distance and look at the interventions and the way of organizing care we're looking for, we should look at those interventions and those techniques where we improve the outcomes for patients and at the same time reduce the cost of treatment and reduce the burden of treatment for society. I think that's the challenge, and that's something I wish you all, that you can start thinking to your own way of working and look for those practice patterns, for those techniques which both improve outcomes for patients and simultaneously reduce the burden for society. Thank you.
Thank you so much, Willem Jan. It was really a great overview and really clear on the premise of value-based healthcare. And in theory, it's so elegantly simple, the formula, and I really appreciated the more famous formulas in the past. And I wanted to ask you, maybe in a couple of decades from now on, will they look back at the value-based healthcare as really a fundamental change in clinical medicine? What are your thoughts about that?
I think it fits in a time where we pay more attention to what's really important for patients. And it's not only value-based healthcare which does so. I think if you go back to the roots of evidence-based medicine, there is also the patient focus in there. And normally in evidence-based, there are three circles in evidence-based medicine. It's the evidence, the scientific evidence. And if we talk about evidence-based medicine, we normally focus on that topic, but it also contains focus on clinical, the clinical knowledge of the professionals. And there is this third item, which is part of the original idea of evidence-based medicine, is the patient preference. So I think there are several streams and several major ways of thinking, which all combine these aspects, and I think value-based healthcare is one of them. But it pays real attention to affordability as well. And actually, if we have the oath of Hippocrates, which something we all promise the day we graduate, it's all in there to focus on the interests of your patients, to look at the quality of care you're delivering, and to keep care accessible as well. So actually, you do promise to pay attention to all these aspects the day you graduate.
Yeah, I think we've all made that oath, and I think it also resonates with us, and to really strive for getting the best outcomes possible for our patients in our office, but also on a more broader national or societal level. Indeed, I do want to ask the audience to send in questions. At the end of the webinar, we can try to answer as much of them as possible. I think, Willem Jan, for the sake of the time, we'll transition to the next speaker, but I hope that you stick around for the Q&A at the end of the webinar. So the next speaker is also a fellow countryman from the Netherlands. It's Paul van der Nat. Paul van der Nat is a physicist by training, but he has made a transition to the hospital and has worked for a number of years in the Santeon hospitals, the hospital where Willem Jan Bos is also working. And he is heavily involved in implementing value-based healthcare in daily clinical practice. And he is also a professor in value-based healthcare at the Radboud University hospital in Nijmegen. So I think a really experienced speaker, and we're really happy that you could join us today, Paul. So I'll be giving you the screen.
Thank you very much for the introduction. And I must say, I really liked the first slide of Willem Jan, making the link between my previous life and my current life, physics and healthcare. I'm moving from the theoretical introduction to the practical example. So I will tell a little bit in the next 15 minutes about how Santeon is implementing value-based healthcare. So next, let me see. Yes, so Santeon is a group of hospitals, 7 hospitals spread out over the Netherlands with national coverage, and can best be described as really a learning system. We try to work together to learn from each other and improve healthcare together. So I will show some examples of that in my presentation. And to give a little bit of a feeling on the size of Santeon, I have some key figures here. So maybe most important one to notice here is that Santeon together covers about 10 to 15% of national volume of hospital care. However, of course, I should be a little bit embarrassed by introducing ourselves in this way, because we were supposed to talk about value and not about volume. So I'll quickly move on to the next slide. Because value-based healthcare is really our guiding principle. I can honestly say that if we didn't start implementing value-based healthcare together, Santeon would not exist at this day. It's really the fundament. And to go a little bit deeper into what Santeon is doing, we have 5 strategic priorities within Santeon, and at the core is our Better Together program, which is really the value-based healthcare program. I will be speaking about that. And it's the fundament also for all the other strategic programs that we have in learning, training, in the way we create a sustainable business model for our hospitals, in the way we realize virtual care. And we have a data platform called our Health Intelligence Platform, Santeon HIPS, which is really the IT fundament of how we work together. And I want to show you a little bit more on the governance, and then I will go into the really interesting part of value-based healthcare. But I will come back to this picture a little bit later as well. So Santeon is really it's a collaboration. So it's not one formal hospital, which people sometimes think. It's really 7 independent hospitals with each their own board of directors, and we work together around these strategic priorities, which are set up in large programs. And as Willem Jan introduced, we use the value agenda to guide our value-based healthcare implementation. And as it was introduced by Willem Jan, I will not go into the details of each of these elements. I do want to stress, maybe we can come back to that in the discussions or in the Q&A, that at the center is really a difference, a change in culture. Value-based healthcare implementation, it is often presented and seen as something quite technical, like you measure outcomes, you have to build a data platform, the shared decision-making implementation. There's all tools and tricks to do this, but if you do not have a certain culture that you want to actually deliver value and that you want to work together as a multidisciplinary team, then it doesn't really work. But let me go through a number of these elements that you've seen here. So for us, it all starts with setting up multidisciplinary improvement teams. We do that for each of the conditions in our value-based healthcare program. And I put really the patients at the top of this list. So 1 or more patients are part of these teams, and then all the different disciplines are involved. We have a project leader supporting this, and last but not least, we have always a data analyst who is supporting these teams, which I think is one of the best, newest additions to, let's say, the professions we have in healthcare. Very much appreciated new profession. And when we set up these teams, then we start, after we've set them up, we start standardized improvement cycle. And in practice, let's say, to explain is very easy. So we set up a team, and we start measuring outcomes. I will show in the next slides, and we do that with a common definition for each of the Santeon hospitals, and we compare. We compare our outcomes, and we use that as a basis for learning from each other, starting discussions. And here you see an example of what kind of indicators we look at. So it's not only outcomes. We look at outcomes, costs, process indicators, and we combine that in a scorecard, and we measure these outcomes together. And these kind of scorecards we have for each of the conditions in our value-based healthcare program, which now includes 16 different medical conditions. So little bit of a recap. This means that for each of these 16 medical conditions in each of the 7 hospitals, we have a multidisciplinary team, and they convene. So it's not completely true, because not all medical conditions are being offered, or the care for each medical condition is being offered in each hospital, but give or take, we have 80 or 90 of these multidisciplinary teams, and for each medical condition, they come together to compare the results, the measured results. And I want to show just briefly 2 examples on how this works. And I personally really like this example. So this is an example from birth care. And one of the indicators that we look at is the percentage of serious ruptures. I've shown here the results for each of the 7 hospitals. Here it's not with the names of the hospitals, because it's not published data. But of course, you see here that hospital G should at least be a little bit worried. This is actually true. And because it was actually St. Antonius Hospital that was showing the worst outcomes, we're really worried. And what happened is that after you challenge the data and think that probably the data are incorrect, you start discussing with each other. And it turns out that some of the other hospitals had a different technique that they used during the delivery. And this technique was actually used and shared with the other hospitals. So what happened is that one of the hospitals, I think it was OVG, was starting to train the healthcare professionals from the other hospitals. And this led over time to an improvement for our hospital, St. Antonius Hospital, over the years. And this is really the basic idea of what we're doing. I want to show another example as well, which the previous speaker can tell a little bit more about than I can, but wanted to put it in anyway, and that is that we're also working a lot on more the personalization of care. We do that together, and this is a very nice example where a dashboard was developed, a patient dashboard, where you can actually see the outcomes, the prompts, the quality of life over time. And this is being shown in the clinic also to the patients. And this is a development in which we work together between Santeon hospitals to improve also in this way the care delivery. So these were just 2 very brief examples, and our philosophy as Santeon hospitals is that we actually publish our results, or that not so much scientifically, we do that as well, but we make the results available on our website through publications that we put on our website of Santeon. And we typically run through 3 phases of development, which you see in this table here. You see on the rows, you see the different medical conditions in our value-based healthcare program, and the colors are the different stages of development of the teams, where phase 1 is a phase where we start comparing, learning from each other, but let's say in an internal with an internal focus. So the results are not published yet. In phase 2, we actually do publish these results. This is an example of that for inflammatory arthritis. So we put these reports on our website. We share the results, and in phase 3, we try to define also our ways of working. So we see differences in our outcomes. In phase 1, in phase 2, we publish them, and in phase 3, we also try to come up to a standard of care together. So this is in a very short presentation, the basic setup of the value-based healthcare program of Santeon, and I wanted to go through a number of the lessons learned, and these are lessons. We can have a very long list of lessons learned, but these are some of the most important ones that I want to point out. The first one is that transparency and trust is really essential if you start implementing value-based healthcare at all different levels. So at first, the transparency within teams. The people within one team have to trust each other from the different disciplines, have to be willing to share outcomes and to dare to be vulnerable, to discuss them, and sometimes to admit that things can be improved. But also the trust between teams. So within Santeon, it's the trust between the different hospitals. And then thirdly, it's also the trust between the different organizations. So the different healthcare providers along the care delivery value chain, along the with primary care, secondary care, but also between health insurers and healthcare providers and industry. So in all these different kinds of collaborations, the transparency and trust I've seen in the last years are really essential to move forward. Then another topic is that value-based redesign of organizations is really needed. This is a topic that we can spend hours talking about in itself. But what I mean by that is that it's not enough to just set up teams. If you set up multidisciplinary teams, you start to change the way you're organized as a healthcare provider, and you have to think about that. What kind of mandate, responsibilities do these teams actually have? Do they formally report on outcomes and costs? What are the consequences of that? The third one is that we have learned and are still learning, because we're not there yet, that it's about the patient, but also with the patient. So we are including the patient in these multidisciplinary teams. But to be honest, it's more of a principle point that we said they have to be there. But how you actually do that, it's almost a science in itself to set this up properly. So we're still developing that. Then the fourth, and I don't know if you recognize this, but I think you do probably recognize it, is that the tendency in hospitals, and especially in hospitals that are innovative and trying to do research, that they do not particularly like to implement new things that they didn't think of themselves, that they didn't invent themselves. And I think this is actually exactly what we have to do. So we have to steal ideas from each other and proudly copy from each other to move forward. That takes a different type of mindset. And fifth, if you're wondering after the presentation of Willem Jan and mine, if it's worth it with all this hard work, yes, it's definitely worth it. There's a lot of good examples coming out, and I will share in the next slide a number of publications where you can find more details on that. one of the challenges also that I see is that improving outcomes does lower costs. There is some evidence on that, and I see it in my practical experience. However, it's sometimes difficult to cash them. So sometimes the lowering of costs is not directly seen on the, let's say, the budget of the hospital or the hospital departments. That might be outside of the hospital, difficult to cash. Current challenge for us is implementing virtual care, so telemonitoring. And I just wanted to share with you that here you see that different kinds of large programs are coming together, because we actually use our structure that we've set up on medical conditions to implement virtual care. So if we want to implement virtual care for COPD, we use our multidisciplinary team for COPD to do it. So that's also a good, large advantage of value-based healthcare. So that's where I want to end. If you're interested in further reading also, let's say, I wanted to share with you the publications that I've been working on with a lot of colleagues that might be interesting. Thank you very much.
Well, thank you so much. That was really a clear and inspiring presentation, and it really has given us an insight in the Santeon way of continuously improving outcomes, learning from each other, and also I think being vulnerable. And I really appreciated your comment on sort of cultivating that culture of improving, and I think it's good to bring that into discussion at the end of the webinar also with Willem Jan. I just had a quick question for you, Paul. Was you mentioned the 16 medical conditions that Santeon is working on in terms of the multidisciplinary programs and the outcome improvement. And I was wondering sort of the choice of these 16 conditions, because when I look with it with a dermatologist view, I see there are no skin diseases, for instance. So I was wondering, what is the sort of the discussion around that?
Yeah. Just to give a quick answer on that as well. It's a very practical reason. So first of all, volume of patient volume, strategic priority. But above all, one of the things that we look at very clearly is, are there people like, for instance, Willem Jan is, who are very enthusiastic, who can drive this change? So enthusiastic medical leaders have been the most important element of success. And we kind of look at the Santeon hospitals to see where there are people to actually drive this change. And especially in the beginning years, that was very important. Now it becomes more of the way we work, a new way of working. Yeah.
Thanks so much, Paul. I think we'll continue the discussion at the end of the webinar.
Yes, I think it's my time to introduce you now, Dr. Deepak Balak. He is a dermatologist at the Leiden University Medical Center. He was our IPC fellow in 2019. His clinical interests are centered mostly about the impact and management of the inflammatory and autoimmune disease. His scientific interests include translational medicine and clinical drug development and evaluation in the field of chronic immune-mediated inflammatory skin diseases as psoriasis, from which we'll have an example now with Dr. Balak telling us what exists in dermatology and psoriasis. Please.
Thanks so much, Ricardo, and it's really a pleasure to continue or following Willem Jan and Paul's presentation, because we've heard about sort of the attractive premise of value-based healthcare in that we can improve the care that we give to our patients, while at the same time trying to temper the rising cost in healthcare. And it really raises the question, what about skin diseases and what about dermatology? Can that be benefit for us, for our discipline as well? And I think at the moment, our specialty is lagging a little bit behind other specialties. When you take a look at the literature, there's not really much published on value-based healthcare for skin diseases. However, there are multiple initiatives present that are start looking to introduce this value-driven care for several skin diseases. And for the next 10 minutes or so, I will give you a high-level overview of some of these initiatives in dermatology with a focus on psoriasis. And I'm going to talk about three areas. The one is the outcome measurements in daily practice. The second one is how can we deliver patient-centric and holistic care. And finally, really briefly discuss payment models and how that can change in the setting of skin disease. So just really a step back and talk about why it's really important to have these outcomes that voice that give the voice to the patients. And this is a study published by Professor van der Kerkhoff, who's also on this call a couple of years ago. And I really like to show this because when you ask a physician, what is the most bothersome thing about psoriasis, you see that more than half of the physicians in blue say, well, it's the location and size of the skin lesions. But if you ask the exact same question to a patient, then you see a completely different response, and that things like itching and pain and scaling are really important for the patient. And it's really too important, I think, for a physician to take the patient's expectations and into consideration. And you can only do that by asking and including the patient's voice. So I think that's really the importance of measuring outcomes. And then, of course, is the question, so what are the outcomes that matter most to patients? And there are multiple initiatives really to help us do that in clinical practice. And one of the larger organizations is the ICHOM, the International Consortium for Health Outcomes Measurements, who's really doing a robust methodology approach to develop and implement these so-called outcome measurement sets that are condition specific and that are helpful to inform a value-based healthcare-driven care. And you can see some of the areas in which ICHOM has done the development of these outcome sets, for instance, cardiometabolic, the renal area in which Willem Jan Bos also did a outcome set for chronic kidney disease. But you see that in these set that are presently available, skin disease is not one of them. Fortunately, there are indeed initiatives going on to improve outcome measurements in dermatology. There are several organizations, such as the Court-Cousin collaboration, C3, the IDIOM, the International Dermatology Organization that is focused on outcome measurements, and the HOME initiative, which is focused on atopic dermatitis. And these are all international organizations that have multiple stakeholders involved, especially the patient, but also payers, researchers, etc. And they try to develop a minimum set of outcomes that can be used for a specific condition. And there have been initiatives for diseases such as psoriasis, but also for diseases such as hidradenitis suppurativa, cutaneous lymphoma, but also patient with itch. And it's good to realize that most of the efforts that have been done in dermatology and that are presently ongoing, most have a focus on research. So sets that can be used in clinical trials to harmonize the outcomes so that you can later on use them in, for instance, network meta-analysis to compare across clinical trials, but also for daily clinical practice registry with a focus on research. But the question really is, can we use these sets also to inform and improve the quality of care in daily clinical practice? And that's not a one-on-one translation. For example, this is a core outcome set for atopic dermatitis developed by the HOME group. And you can see that the outcome set consists of 4 of the domains. So signs, symptoms, quality of life, and long-term control. So these are the domains, and each domain has one or several measurements that you can use to measure that specific domain. So for instance, for the domain of clinical science, the preferred instrument to use is the EASY. For quality of life, it's the DOQI for patients 16 years or older. This is a set that is specifically intended for clinical trial use. And how can we then use that in clinical practice? One of the ways that we can use these sets is to do what we call treat-to-target approach, in which we have the predefined treatment goals that are often defined by these measurement instruments, and that can really help to drive decision-making in initiating, but also monitoring treatments. For instance, if you look at the DOQI, you see that after 3 months of initiation of treatment, the DOQI score should be at least 4 points decrease. And after 6 months, then the treatment goal is to have an absolute score of 5 or less. And if you don't get that treatment goal, then you can either adjust or switch from the therapy. So that's how we can use sort of these outcome measurements to drive clinical care. But this is, of course, not the sort of full cycle of improvement that Willem Jan and Paul were talking about, how we can sort of on a meta-analysis level improve the care that we give. So I think there still need to be work done in the field of dermatology in terms of resources, both in time, but also the digital infrastructure that is needed to collect the outcomes and compare that across different centers. And I think the final point of the culture change that is really needed in terms of being vulnerable, learning lessons. I think these are things that need introduction in the field of dermatology. I would like to introduce the work of Professor Jo Lambert, who is a dermatologist in Belgium. She's based at the Ghent University Hospital, and she's really pioneering the field of value-based healthcare in dermatology, and specific also for psoriasis. And her research group has developed an outcome set, so a minimum set of outcomes, domains, and instruments that can be used to support a value-driven approach, specifically for daily clinical practice. And using robust methodology, the group of Professor Lambert has identified 21 outcomes that matter most to patients with psoriasis, and they found 12 measurement instruments to measure these 21 outcomes. And it really attests to the importance of the patient voice, because the majority of the instruments are patient-reported, 8 of them, whereas 4 are provided by providers. And Professor Jo Lambert's research group is now developing or further validating this outcome measurement in an international setting. And what the group of Professor Lambert now is doing is an innovative clinical trial in Ghent to really see if we can implement this value outcome set in daily clinical practice, and can we indeed use that as a way or as a tool to enhance and improve the value that we create for patients. So this trial is now underway, and I think the results are eagerly awaited because this, I think, will be the first supporting evidence to move towards a value-based healthcare approach for a skin disease. I would like to also take one step back in terms of the holistic care, because when we think about psoriasis, of course, we do see the skin lesions, the plaques, but that's only the sort of the external view, because of the systemic inflammation. Patients with psoriasis, as you know, suffer from comorbidities such as cardiometabolic diseases, arthritis, and also mental disorders. And if we only focus on the skin, we will not do good to the complete patient. And so I think this really attests to do this holistic multi-specialty approach for patients with psoriasis, but also for other chronic skin diseases that have this multifaceted aspect with multiple comorbidities. And I think in the literature and perhaps also in your own hospital, there are initiatives really where you have these multidisciplinary team approaches in which you, for instance, would have joint clinics with, for instance, rheumatology for connective tissue diseases like such as systemic lupus, but also psoriatic arthritis. My own hospital in Leiden, for instance, also has a multidisciplinary clinic for cutaneous lymphoma, in which we would have close collaborations with colleagues from the hematology department and the radiotherapy. And sort of these joint clinics do offer improved outcomes compared to this sort of silo-based care that we traditionally have. But these are not, I think, the complete full-based healthcare approach that Willem Jan and Paul has shown. So I think there's more work to be done. And I think one of the possible methods that we can learn from is the integrated practice unit, in which the care is organized around the patient using multiple disciplines, rather than the patient being sort of rotated from one specialty to another. And I will not go into too much detail on this topic, because this will be the topic of the next webinar in this series, which will take place on September the 20th. So I would cordially invite you to join that and to see how we can learn from other disciplines who have this more IPU approach already implemented. So finally, this is my final topic, is the topic of the payment models, because in the formula that Willem Jan and Paul has introduced, you have the outcomes over the costs. And I think one of the items in value-based healthcare is really re-informing or restructuring actually the financial structure to reward not volume, which is sort of the gold standard at the moment, but really moving towards more a reimbursement for value. And I came across a really interesting pilot study being done by colleagues from Denmark, who have piloted a outcome-based reimbursement model based on the patient benefit index. So these are treatment goals that the patient himself has set, and you would then get reimbursed if you can reach or if you can get those targets, yes or no. And I think an interesting part also in this model is that they also took into consideration factors that have been known to decrease the chances of treatment response. For instance, patients who are obese or who are smoking, they might have less odds to have successful treatments. So the reimbursement structure is really dependent also on these risk factors. And I think this is one of the first ways in which we can transition also in dermatology from a fee for service model to a fee for value reimbursement. So I come to my final slide, and I think it builds upon the two previous speakers, that value-based healthcare has a lot of benefits in the first place for the patients and also then for the providers, but also for multiple other stakeholders that take a role in healthcare, such as the payers and suppliers. And I think it also has benefits for the society as well. And I think that these benefits will, I think, trigger hopefully you as specialists in the dermatology field to start looking at value-based healthcare and see it as I think, a really interesting and innovative approach to restructure the healthcare with the ultimate goal of providing better care for our patients. So with that, I would like to end my presentation, and we will stop sharing my screen. So I think we have still a couple of minutes for a Q&A. I think, Ricardo, are there any burning questions from the audience that we can address?
Yeah, before we move to them, Deepak, I'd just like to highlight really the importance of this multidisciplinary approach. Paul mentioned it in his talk. You stressed it in your talk, and how important it is, not just for psoriasis, if you really diagnose early enough a patient with psoriatic arthritis, how this in the future will improve health outcomes and lower costs. It might in the beginning look as it will just higher costs if you offer this to all patients, but it really certainly pays in the future for our patients, not just in dermatology, but I consider in most chronic diseases. Peter, you're here with us. I saw you sent us a question. Please feel open to ask the question.
Well, I am very much in favor for value-based healthcare. And also in my teaching, I refer to this not only in teaching sessions in Europe and North America, but also in underserved areas of the world. For I think to create value, and the models behind this are very important. I have also some concerns with respect to the implementation. And one concern is how to find the right outcome or outcome measures. On one hand, you can select an outcome measure which is not disease specific, like the EQ5D, but then you are judging the severity of psoriasis with the EQ5D with a question, for example, to get easy in or out the car. Well, as dermatologists, but not only as dermatologists, we know that that is not the most crucial question to assess quality of life. And we have also problems in elderly patients where for example, DLQI also often with many items get the addendum not relevant. Well, that is the question sometimes, whether it's relevant or not. So I'm struggling with outcome measures, the complexity of the disease. And so my question is a little bit, what should be done in outcome measures? And how many outcome measures can we combine? For the patients have not the whole day the time to fill out the different questionnaires. And
would you like to comment?
Yeah.
Willem?
Maybe I should comment. I chaired an ICHOM session, a group to define a set. Actually, you're asking lots of questions. And so you're asking about outcomes, you're asking about specific outcomes, PROMs, the patient-reported outcomes, which might be a burden for patients. And I do also have experience with the National Kidney Registry in the Netherlands. And if you define such a set, I think you should see it as an agenda. You should not immediately try to implement everything. That will be a disaster. But you should start looking what you have, which is easy to collect from your electronic patient records. And yes, we should redefine our electronic patient records accordingly and try to convince the national vendors of IT systems to use predetermined outcomes. And we have a beautiful example at Leiden University at the Department of Neurology, where neurologists had to register the type of stroke 8 times in their electronic patient record. And of course, then you have non-alignment. We redefined their neurology records, and now they only have to define it once in a correct way. And the system takes over the other 7 times. And then it's really helpful for professionals. If they do it correct the first time, it really helps them later on, helps them writing their letters to the GP, etc. The other thing is you should talk to your patients, which outcomes to collect. And then the third issue, the patient-reported outcomes, I think it might be very helpful, for example, to give something of a figure to itching. If I think of dermatology and of psoriasis. On the other hand, when I started doing this work, I thought patient-reported outcomes are also ideal for benchmarking. And my ideas developed and became contrary. I think they are ideal to have individual discussions in the office. What's important, what's bothering you as a patient? And you might even ask it to have an open question, apart from all the specific questions. What do you want to discuss next visit? And then it's very helpful. And I also have patients who might have a list of 30 items which bother them. If I see shortness of breath or lack of energy is a generic item, I can say, well, if I look at your questionnaire, I think lack of energy is a general issue. Shall we start there and leave the itching or the redness of your skin a little bit behind and reserve that for the next visit? And people are really happy if they see that you use the prompts. So 2 lessons, use it in individual patient care. And if your patient fills out a questionnaire, mention it and use it in your next visit. Otherwise, they'll stop immediately.
Great.
Thank you.
We have run out of time, perhaps time for one last question from our attendees. For you, Deepak, now that new biologics offer such high rates of near or almost clear skin, how does this alter all of these measures of quality? Fast question, fast answer.
Oh, that's not an easy question to answer, but I do think that, of course, skin is the improvement of the skin is one thing, but, the quality of life, for instance, the joints, the itching, but also sometimes the fear of losing response are all factors that I think are really important. So I think my quick answer would be we have to have this holistic, multidisciplinary view, not only looking at the skin.
Fantastic. So I pass the word to you.
Yeah, unfortunately, we have run out of time because I was really looking forward to the discussion about the culture, Paul and Willem Jan. But I think we have to reserve that for another time. I would thank you both for your really excellent and inspiring presentations. And I think we, in the field of dermatology and psoriasis, can build upon your presentation. So thank you so much. I want to thank the IPC for their wonderful collaboration and making this webinar possible. And finally, I would like to thank Ricardo for the co-chairing this session and the attendees for their commitment of joining us today. And I would like to invite everyone to join the second webinar on September 20th, in which we will go further on the value-based healthcare in dermatology. Take care and hope to see you then.
Hopefully see you at the next webinar. Bye-bye.